Welcome to PRISM Rounds, the audio journal club where we basically break down one study at a time for our ICU, ED, pulmonary critical care, and sleep medicine clinicians.
And trainees, too.
Right, definitely trainees. We're keeping the focus heavily on bedside translation and, practical teaching.
Which is exactly what we need when looking at the literature.
Exactly. So, for today's deep dive, we are jumping into the R2D2 ICU trial.
Published in JAMA, March of 2026.
Yeah. And it's all about physical restraints in mechanically ventilated ICU patients.
It's a heavy topic, literally and figuratively.
It really is. I want to give you the bottom line up front before we really get into the weeds.
Lay it on us.
So, using fewer restraints on these intubated patients did not improve delirium or coma.
Right, which was kind of the big hope.
Yeah, but, and this is the massive takeaway, it also did not increase harm.
Which makes this a profoundly actionable negative trial.
Exactly. It's a negative trial with incredibly practical implications, basically because it challenges this deeply ingrained reflex of restraining every single intubated patient.
Yeah, the study asks a very simple, almost dangerously simple bedside question. Like, do all ventilated patients actually need restraints?
And the data says no.
Right. The answer really seems to be no.
So I want to set this scene for you, the listener, because if you work in critical care, you know this environment intimately.
You live it every day.
You really do. Just imagine waking up in a strange room, the lights are blinding, you have no idea if it's day or night.
You can't speak.
You can't speak at all. There is a rigid plastic tube forced down your throat.
Pushing right past your vocal cords.
Yeah, and every time you swallow, you choke. And you're hearing all these alarms blaring from machines you can't even see.
It's terrifying. Your brain is literally swimming in this cocktail of sedatives and systemic inflammation.
Right. So instinctively, you reach up to pull that suffocating plastic tube out of your airway. Because, of course you would.
It's a basic survival reflex.
But you can't. You try to move your arms, and you realize your wrists are tied tight to the metal bed frame. You are completely trapped.
And for decades, modern critical care medicine has called this practice patient safety.
We just call it routine.
Yeah, just what you do. But today, we are unpacking this newly published data that suggests it might actually just be torture.
And entirely unnecessary torture at that.
It really is one of the most jarring paradoxes in all of medicine.
How so?
Well, think about it. We use the most advanced technology on Earth to save a life, right? Like ECMO, continuous renal replacement therapy.
Targeted temperature management.
Exactly. Millions of dollars of life support equipment. And yet, our primary method for protecting all of that relies on literal canvas straps.
Canvas straps from, the 19th century.
Right. It's absurd when you really frame it that way.
So if you're joining us right now on your commute, or maybe you're charting at the nurse's station, you know exactly what we're talking about.
You know the exact canvas straps we mean.
Our mission for this deep dive is to dissect this landmark trial that just shatters the foundation of how we manage agitated, intubated patients.
The R2D2 ICU Trial.
Yeah. And we've got a massive stack of literature here. We're synthesizing the original investigation by Dr. Romain Sonneville and his team.
Across 10 different French intensive care units, no less.
Right. Plus the accompanying editorial and a full breakdown of the bedside translation.
Because this paper is generating a massive shockwaves through the critical care community right now.
And it should. It tests a dogma that we all just accepted as this grim, unavoidable reality of the job.
Yeah. Earlier you called it an actionable negative trial.
I did, yeah. Which sounds like an oxymoron, doesn't it?
Usually a negative trial means failure. Like, you spend millions testing a new sepsis drug, the data shows no improvement, the trial is negative, and you shelf the drug.
And?
Exactly. But in the context of behavioral interventions, an actionable negative trial is a totally different animal.
Because failing to show a clinical difference here actually shatters the habit.
Right. They basically proved a negative to force a positive change.
The data is just staring us in the face, asking, if tying someone's wrists down doesn't heal their brain faster,
and leaving their hands free doesn't cause them to pull out their life support,
then what is our medical justification for doing it?
To really answer that, we have to look at the reflex. Because no clinician actively wants to tie a patient down.
God, no. It comes from a place of intense, totally justified fear.
Absolutely.
Yeah.
Think about that patient with severe ARDS. They've got the endotracheal tube, maybe a central venous catheter in their jugular.
Infusing, high-dose norepinephrine just to keep their blood pressure up.
And an arterial line in their radial artery. They are biologically tethered to the wall.
And the absolute nightmare scenario, the thing that keeps ICU nurses awake at night, is self-extubation.
Right. If a delirious patient thrashes, grabs that tube, and rips it out with the balloon cuff still inflated,
Ugh, the damage is just catastrophic.
the trauma to the vocal cords alone can be permanent, not to mention the immediate loss of the airway.
Which swells shut almost instantly from the trauma.
And then you have minutes, literally minutes, to get an attending to the bedside, push induction agents, paralyze them, and attempt a bloody emergency reintubation.
Before they go into cardiac arrest. So when a nurse sees a patient start to stir and reach for their face, the reflex kicks in.
I cannot let that tube come out. I must secure their hands. It's a purely defensive posture.
But in a lot of units, especially ones dealing with, chronic understaffing, that defensive posture has metastasized.
It becomes systematic. Prophylactic restraint, the straps go on the second the tube goes in.
Just a necessary evil. But the JAMA editorial we have here really forces us to look at the evil side of that equation.
Because we're so laser-focused on protecting the plastic tube, we ignore the foundational damage we're doing to the human being.
The physical harms alone are severe. Deep tissue pressure, ulcers on the wrists from straining against the straps.
Severe shoulder dislocations from thrashing while anchored.
And peripheral nerve damage. Long-term neuropathies just from the straps compressing the radial or ulnar nerves.
But honestly, the physical damage pales in comparison to the psychological devastation.
The psychological mechanism is fascinating and horrific.
Right, because how does the brain orient itself? Sensory feedback.
Yeah, you touch your face, you feel the bed shades, but an ICU patient with acute delirium, their brain is basically glitching.
It's desperately searching for sensory input to make sense of the chaos.
And physical restraints are basically the ultimate sensory deprivation trap.
Exactly. The brain is hallucinating threats, dumping adrenaline into the bloodstream. It triggers a massive fight-or-flight response.
The patient just feels this overwhelming urge to flee, but their limbs are immobilized.
So the brain can't execute the survival commands it's sending.
Which creates this massive cognitive dissonance, right?
Yeah.
It just spirals the delirium further into extreme agitation.
And then the clinical team sees that agitation and thinks, oh, they need tighter restraints.
Or more chemical sedation. It's a horrible feedback loop.
The sources draw a direct line between this experience and severe long-term psychological morbidity.
We're talking profound PTSD lasting months or even years after they leave the hospital.
There's a qualitative study by Perez and colleagues highlighted right at the top of the JAMA editorial.
Oh, I read that. They interviewed survivors of critical illness about what it felt like to be tied down.
The quote is haunting.
Let me read it. The patient said, "I was already fighting so much. The need for a drop of water and any basic human need was being taken away anyway. And then not to have the use of your bodily parts, your hands to hug somebody, to wipe away tears, to help you talk."
Man, that just shatters the clinical detachment we carry on rounds.
It really strips away the sterile language of patient safety. You realize you're taking someone at their absolute most vulnerable.
Someone who has already lost control of their breathing, their bowels, their voice.
And we are stripping away their final fundamental agency, the ability to just move their own hands.
And the blast radius of that trauma extends to the family, too.
Oh, absolutely. The editorial talks a lot about the ethical toll.
If you've ever had to escort a family member into the ICU for the first time, it's a delicate, volatile moment.
And walking in to find your husband or your mother tied to the bed rails, it's incredibly traumatic.
They often feel like their loved one is being treated like an animal, which loops right back to the bedside nurse, causing profound moral distress.
Right. Moral distress being that psychological trauma when you know the right thing to do, but institutional constraints make it impossible.
They're caught between beneficence, doing good by protecting the airway, and non-maleficence, doing no harm by avoiding psychological torture.
It's an agonizing daily calculation, but what's so striking in the data is how this calculation changes depending on where you are geographically.
Yes, managing an airway is a universal biological science, but physical restraint use varies wildly across the globe.
The sources note that in some European ICUs, physical restraints are incredibly rare, like an extreme last resort.
But in other regions, including a lot of North America, it's nearly 100% default restraint for all ventilated patients.
Which proves a vital point. This isn't a universal biological necessity. It's a cultural practice.
Right. It's learned behavior dictated by unit policy and staffing, not unassailable science.
But, and I have to push back here, if you are that nurse at 3 a.m., philosophy doesn't keep the tube in the trachea.
Fair point.
If a delirious patient's hand is closing around their life support tubing, tying their wrists feels like the only logical option.
Basic physics.
And that exact tension, the logic of physics versus psychological trauma, is why we've been paralyzed by this dogma.
We just didn't have the rigorous randomized controlled data to tell us what actually happens when we untie the knot.
Until the R2D2 ICU trial.
So let's look at how they built this study. Because doing a randomized trial in a chaotic ICU environment is incredibly hard.
It's a masterclass in pragmatic trial design. They did an open-label, multi-center, randomized clinical trial across 10 ICUs in France between January 2021 and January 2024. And they randomized 405 critically ill adult patients.
All receiving invasive mechanical ventilation.
And these were sick patients, median age 65, about 60% male.
Over 90% admitted for severe medical reasons, not just routine post-op care. Acute respiratory failure, profound shock.
We can quantify that with their baseline SOFA scores, the sequential organ failure assessment.
Right, which tracks organ function. The median SOFA score here was a 7.
For any early trainees listening, a SOFA of 7 is not trivial. A 1 or 2 is maybe some supplemental oxygen.
A 7 means multi-system organ failure.
Kidneys shutting down, bilirubin spiking, requiring continuous vasoactive drips for brain perfusion. These patients were on the brink.
A true hardcore critical care cohort, and they randomized them 1-to-1 into 2 drastically different strategies.
Group 1 was the low-use strategy, 196 patients. The protocol mandated that wrist restraints be actively avoided.
They were explicitly instructed not to tie them down.
The only exception was for severe, unmanageable agitation, which they defined strictly using the Richmond Agitation Sedation Scale.
The RAS score.
Right. Remind us how that scale works.
It runs from -5, which is completely unarousable and comatose, up to a +4, which is overtly combative and violent.
With 0 being alert and calm.
Exactly. So in the low-use group, they could only use restraints if the patient hit a RAS of +3 or +4.
Meaning they were highly agitated, actively pulling at tubes, restraint by exception.
Now, group 2 was the high-use strategy, 200 patients.
This represents usual care for a lot of hospitals. Wrist restraints were applied systematically from day 0, default setting.
They did reassess daily. The restraints weren't permanent, but the hurdle to remove them was very high.
They had to be fully awake and cooperative, or successfully extubated, and crucially, not delirious.
Which brings in the CAM-ICU screening, the confusion assessment method.
Right, because you can't just ask an intubated patient what day it is. You have to test for inattention and altered consciousness.
And the protocol required this twice daily. If they failed to CAM-ICU, the straps stayed on.
So those are the two paradigms. Freedom by default versus immobilization by default.
And the next critical question was, how do we define success? What's the primary outcome?
They chose days alive without coma or delirium over the first 14 days, which is a brilliant metric.
It's the gold standard in modern critical care trials. It elegantly captures both mortality and severe brain dysfunction.
Because obviously you have to be alive to get a delirium-free day. If they die on day 2, the score is 0.
Right. And beyond survival, it treats the brain as an organ capable of profound failure, just like the kidneys or lungs.
We used to just focus on the heart and lungs. Did they survive the code?
But now we know delirium and coma are massive, independent predictors of mortality and long-term cognitive decline.
So this metric tells us the quality of their neurological recovery.
The researchers' underlying hypothesis was that the physical restraints were actually an independent variable driving the delirium.
Like the sensory deprivation and frustration were keeping the brain toxic.
Yes. The theory was that if you remove the straps, the brain orients itself, delirium clears, and you get more healthy, awake days.
There's an elephant in the room with the trial design, though. You mentioned it was an open-label trial.
They did, yeah.
In clinical research, we usually want double-blind, placebo-controlled trials to eliminate bias. If the nurse knows the patient is in the no-restraint group, couldn't that subconsciously alter care?
It's a valid concern, but it's a physical reality of the universe. You cannot double-blind a canvas wrist restraint.
Right. You can't put an invisible rope on someone.
Exactly. There is no placebo strap. The bedside nurse managing their IVs 24 hours a day is going to know.
So how did they compensate for that lack of blinding?
Through incredibly rigorous standardization of every other aspect of care.
Oh, okay.
Analgesia protocols, sedation targets, delirium screening, mobilization, all identical across both groups and all 10 ICUs.
The only independent variable was the threshold for tying their wrists to the bed?
Exactly. So we got the setup. Over 400 profoundly sick patients. Have tied down by default, have given freedom by default.
Monitored relentlessly for 14 days. So let's look at the results. What happened to their brains?
The hypothesis was that the low-use group would wake up faster and have less delirium.
Right. But the numbers tell a completely different story. The low-use group averaged 6.67 coma and delirium-free days.
And the high-use group, the ones tied down, averaged 6.30 days.
That's an adjusted mean difference of just 0.37 days.
With a p-value of 0.51. So, statistically speaking, absolutely no significant difference between the two groups.
I just need to pause on that.
Yeah.
Less than half a day's difference over 2 weeks in the ICU is virtually identical.
Taking the restraints off did not magically snap these patients out of their delirium.
And the secondary neurological outcomes matched that. The incidence of delirium was 62.2% in the low-use group and 67.5% in the high-use group.
Again, a totally non-significant difference.
So the idea that the wrist straps themselves were the primary driver of brain dysfunction, that was false.
It appears so. It suggests that in a population this sick, remember the SOFA, of 7 coma and delirium, are driven by massive systemic factors.
Right, the severity of the sepsis, the neuroinflammation, the heavy sedatives.
Compared to all that systemic shock, whether or not there's a canvas strap on their wrist is basically physiological background noise.
Okay, but here is the crux of the whole debate. If the low-use group didn't get better neurologically, did they do worse safely?
That is the million-dollar question.
Because clinical intuition screams that an untied, delirious patient is going to pull their tube out. Did the self-extubation rate spike?
This is the true headline of the trial. The finding that shatters the dogma.
What were the numbers?
The self-extubation rate in the low-use group was 9.2%. In the high-use group, it was 8.5%.
Wait, 9.2 versus 8.5. That is completely non-significant.
Leaving their hands free resulted in basically the exact same number of pulled tubes.
That defies all clinical intuition. How is that physically possible? If their hands are free, why aren't they pulling the tube?
It forces us to rethink the mechanism of agitation. We assume they pull the tube because they're consciously trying to remove it.
So we physically block the hand.
But what if they're thrashing and pulling because they're tied down?
Oh, the claustrophobic panic we talked about?
Exactly. When you remove the straps, you remove the panic. They might still be delirious, but they aren't experiencing the acute terror of being trapped.
So their resting state is calmer. They just don't have that adrenaline-fueled urge to thrash.
And it wasn't just breathing tubes. Unplanned device removal, pulling out central lines, arterial lines, catheters, happened in only 1.0% of the low-use group.
Compared to 0.5% of the high-use group, we're talking about a tiny, tiny handful of patients.
Taking the straps off did not result in a chaotic, bloody free-for-all, which fundamentally fractures the argument for routine restraints.
You can safely manage the vast majority of these patients without tying them down.
But I know what the skeptical clinician is thinking right now.
Oh, I know too. At what cost?
Right. If a nurse can't use physical restraints, but they're terrified of self-extubation, what's their next move?
They reach for the chemical restraints, they crank up the propofol, they push IV haloperidol.
Did the low-use group just get snowed into a pharmaceutical coma to keep them compliant?
It's the most critical counterargument, but the trial designers tracked this perfectly.
They rigorously tracked cumulative doses of every major sedative and antipsychotic over the 14 days.
Opioids like sufentanil, GABA agonists like propofol and midazolam, haloperidol, dexmedetomidine.
And the results.
Yeah.
The cumulative doses were statistically similar between both groups across the board.
Reducing physical restraints did not lead to an escalation of chemical sedation.
The nurses did not have to heavily drug the low-use group to keep them safe.
That is a massive victory for this trial, because trading physical restraints for chemical restraints is just trading one poison for another.
The editorial vehemently points out that assuming chemical restraint is kinder is a dangerous fallacy.
Chemical restraints have profound side effects. High-dose propofol causes severe hypotension.
Haloperidol can prolong the QT interval, leading to lethal arrhythmias.
So the fact that they maintain safety without more of these dangerous drugs proves we don't have to make that toxic trade-off.
They also tracked physical safety outcomes. Pressure ulcers were 15.3% in the low-use group, 17.0% in the high-use group.
No significant difference. Mortality at 90 days, 37.2% versus 41.0%. Again, a tie.
So we have an ocean of robust data. But if I'm an ICU medical director, I might say, look, the clinical outcomes are basically a tie. Why change our entire established routine if the medical outcomes are identical?
Why go through the friction of retraining the whole staff?
Exactly. And that brings us right back to the ethical imperative of our profession.
If two interventions get the exact same clinical result, but one involves tying a human being's limbs to a metal bed frame.
Restricting their freedom, causing documented trauma and moral distress, you have to default to the intervention that preserves human dignity.
If the medical outcomes are a tie, human dignity wins the tiebreaker, every single time.
Precisely. This trial shifts the entire burden of proof.
For decades, the burden was on the clinician to justify why the restraints should be taken off.
Now, the burden must be on the clinician to justify putting them on.
Because if they don't improve brain recovery and they don't uniquely save airways, default prophylactic use is completely unjustified.
It's a seismic, culture-altering shift. But before we broadcast a mandate to cut the straps off every bed, we need to look at the fine print.
Yes, evidence-based medicine requires context. Who are these patients, and does this apply to every ICU in the world?
Let's check the limitations, because the exclusion criteria tell you just as much as the inclusion criteria.
The researchers were meticulous. They didn't set this up to fail.
So they excluded highly volatile populations where a no-restraint strategy could be catastrophic.
Like severe alcohol withdrawal syndrome.
Yes, alcohol withdrawal in the ICU is a uniquely dangerous beast. The brain's neurochemistry goes into hyper-excitatory overdrive.
Delirium tremens, violent psychomotor agitation, terrifying hallucinations, and the sheer physical strength that is just incredibly difficult to manage safely.
They also excluded patients who already had documented severe delirium prior to admission.
And pre-existing advanced dementia or primary acute neurological disorders like a massive stroke or traumatic brain injury.
Exactly. Populations where the brain's structural integrity or neurochemistry is already profoundly altered.
Their behavioral responses are totally unpredictable. You can't just blindly apply this safety data to a patient thrashing in the throes of DTs.
Okay, so that establishes who this data applies to. Now let's talk about the how.
Baseline sedation levels. This is a vital data point.
Almost 90% of the participants were deeply unconscious at the exact moment of randomization.
RAS scores of -4 or -5.
This is crucial context. Many modern ICUs push for very light early sedation. They want the patient awake, interactive, participating in physical therapy while intubated.
Right. And an awake, interactive patient with a plastic tube in their trachea presents a very different behavioral dynamic than a deeply sedated one waking up slowly.
Since 90% in this trial started out deeply comatose, the results might not perfectly map onto an ICU running a purely awake and breathing protocol.
And there is another massive real-world caveat here, the elephant in the room for modern healthcare.
Staffing ratios.
Yes, this trial was in France. And in the French system, nurse-to-patient ratios for ventilated patients are strictly regulated.
Usually 1 to 2.5, or at maximum 1 to 3.
Meaning one nurse has, at most, 3 ventilated patients.
If you are listening to this in an understaffed ICU in the US or the UK, you're probably screaming right now.
What about my ratios? And you're entirely right to be angry. A 1-to-3 ratio is a luxury in many regional hospitals.
The editorial bluntly acknowledges this in regions where a single nurse has 4 or more highly complex patients.
The ability to provide surveillance with immediate but gentle intervention is just drastically compromised.
It's a simple issue of physical proximity. If the nurse is in room A managing a crashing patient who needs blood,
and the patient in room B starts reaching for their tube, the nurse just physically isn't there to gently redirect their hand.
in those severely under-resourced environments, the physical restraint is functioning as a proxy for the nurse's physical presence.
So if you're a charge nurse in a unit where nurses are routinely tripled or quadrupled with vents,
This trial isn't necessarily giving you immediate permission to throw away the straps.
because the safety net of hypervigilant staffing just isn't there to catch the patient if they do reach for the tube.
The editorial authors explicitly recommend that translating this to the bedside must be calibrated based on local unit culture and actual ratios.
You can't adopt the French lack of restraints without advocating for the French staffing model that makes it safe.
And there's one more limitation I want to highlight about the low-use group itself.
It was a low-use strategy, not a zero-use strategy.
Right. When you look at the raw data, wrist restraints were still ultimately applied to 36% of the patients in the low-use arm at some point.
More than a third still required physical immobilization.
Even in a highly controlled protocol, actively avoiding restraints with excellent staffing.
Roughly 1 in 3 patients became so severely agitated they crossed that RIS+3 threshold and needed the straps for safety.
It's a less restraint strategy, not a utopian zero restraint fantasy.
Also, the 90-day follow-up. They attempted it to assess PTSD and functional recovery, but they hit a high loss-to-follow-up rate.
Out of 405 patients, only 180 fully completed the 90-day assessment.
Which softens our statistical confidence regarding long-term PTSD a bit, compared to the 14-day safety data.
But acknowledging these limitations doesn't invalidate the study at all. It grounds it in reality.
It shapes exactly how clinicians should translate this data to the bedside on their very next shift.
So let's bridge that gap. Let's talk bedside translation.
If I'm an ICU attending or a clinical nurse educator, what is my actionable takeaway?
The ultimate takeaway is a fundamental rewiring of unit culture. Stop using physical restraints reflexively on every intubated patient.
Start using them selectively and with immense clinical justification.
It's shifting from an opt-out culture to an opt-in culture. Right now, a patient is intubated, the straps go on.
And they basically have to prove their sanity to earn the privilege of having them removed.
This trial demands we flip that entirely. Freedom of movement must be the default upon admission.
The sources provide a really clear, highly practical, stepwise approach to managing agitation without defaulting to immobilization.
Step 1 is universal. Optimize analgesia and sedation.
Yeah.
Treat the pain first.
Right, a thrashing patient might not be trying to self-extubate. They might be in agonizing pain from a full bladder.
Or a surgical incision. Or just the brutal discomfort of the breathing tube.
If you identify and treat the pain, maybe with targeted analgesics instead of broad sedatives, the agitation often resolves completely.
And the need for restraints vanishes. Step 2 involves actively preventing and treating delirium.
Diligent detective work. Having the pharmacist check for anticholinergic drugs, making them confuse.
Making sure they have their glasses and hearing aids on during the day so they aren't isolated in a blurry, silent world.
Protecting their sleep cycles at night by minimizing alarms.
Step 3 relies on human connection. Reorient the patient. Talk to them. Tell them where they are and what the tube is doing.
Mobilize them early. Sit them up on the edge of the bed if they're stable, and involve the family.
Having a trusted family member holding their hand can calm a delirious mind way better than a canvas strap.
And then finally, step 4. Reserve physical restraints only for situations with a clear, immediate, and unmanageable safety risk.
Severe hyperactive delirium, violent agitation, or repeatedly gripping the life support lines.
This stepwise approach really elevates the physical restraint from just passive hospital furniture
To a potent, active medical intervention.
Exactly. Right now, they're viewed as part of the bed, like the side rails. But we need to view them with the same caution as a high-alert medication.
It's like antibiotics. Imagine taking a broad-spectrum antibiotic every day, just in case you get a cold.
The side effects, destroying your gut microbiome, antibiotic resistance, are vastly disproportionate to the hypothetical protection.
You only take it when you have an active infection. A physical restraint is the same. It needs a clear, documented clinical indication.
A prescribed duration.
Yeah.
And rigorous daily reassessment to discontinue it the second the acute indication resolves.
You don't leave a patient on high-dose norepinephrine for 2 weeks just because their pressure was low on day 1.
You actively wean it. We need to start titrating physical restraints.
And we now have the robust, randomized data to prove that this doesn't compromise safety or force dangerous chemical sedation.
The lack of increased propofol or haloperidol in the low-use group is the empirical safety blanket clinicians need.
You don't have to trade tying human beings down for snowing them into a pharmaceutical coma.
It's a profound evolution, moving from practicing medicine based on worst-case scenario fear, the fear of the flying endotracheal tube,
to practicing based on objective, compassionate evidence.
The JAMA editorial concludes with a really compelling point about the balance we have to strike.
Hospital administrations have a strict duty to provide a safe workplace for their staff. We can't expect nurses to endure physical violence.
Absolutely. But the indiscriminate default application of physical restraints breaches fundamental community expectations of compassionate, person-centered care.
We have to find a more nuanced balance, and the R2D2 ICU trial provides the empirical foundation to start tipping the scales back toward human dignity.
It really does. It proves that a strategy of less restraint is entirely possible, and most importantly, it's safe.
Okay, we have covered an immense amount of clinical and philosophical ground today.
Let's pull it all together with a quick summary. We started by confronting the reflex,
The deeply ingrained use of restraints to protect airways, and the severe physical and psychological trauma they inflict.
Then we dissected the R2D2 ICU trial. 405 critically ill, ventilated patients in France, randomized to a high-use default strategy or a restrictive low-use strategy.
The neurological results were clear. The low-use strategy did not improve days alive without coma or delirium. The trajectory of brain dysfunction was identical.
But the safety data changes practice. Taking restraints off did not increase self-extubation or unplanned device removal.
And crucially, it didn't require escalating chemical sedatives to keep patients safe.
We acknowledge the caveats. It doesn't apply to severe alcohol withdrawal, and it relies heavily on safe nurse-to-patient staffing ratios.
But ultimately, it officially shifts the burden of proof. It's no longer acceptable to tie a patient down by default.
You, the clinician, must actively justify why the straps are going on.
It's a remarkable piece of literature that will shape guidelines for years to come. But before we sign off, I want to leave you with a final, slightly provocative thought to mull over.
I am always here for a paradigm shift. What is the thought?
We talked about treating physical restraints as an active medical intervention, like a high-alert drug. What if hospital systems took that literally? What if, starting tomorrow, clinical protocols required physical restraints to be officially charted in the Medication Administration Record, the MAR?
Oh, wow. That is fascinating. The MAR is sacred territory in a hospital.
Exactly. Imagine if a physician had to officially prescribe wrist traps in the electronic health record with the exact same regulatory friction as a high-risk opioid.
Wow.
Imagine if the order required a specific dosage defined in hours per day, listed the severe side effects like PTSD and pressure ulcers, and mandated a hard stop date every 24 hours, requiring a new justified prescription.
How drastically would unit culture change overnight?
Right. If typing the order for wrist straps triggered a giant red pharmacy warning on screen about the risk of long-term psychological trauma, would we still use them by default?
That is a brilliant and honestly terrifying question. It's about making the invisible friction visible.
It removes the passivity of the practice.
I strongly encourage all of you listening to bring this conversation and that specific question to your next ICU clinical rounds.
Question the default settings of your own unit's practice.
Because as we've seen clearly today, sometimes the heavy-handed things we do to maintain absolute control in a chaotic environment are just a comforting illusion.
And true precision in medicine means knowing exactly when it's safe to untie the knot.
Just a quick reminder before we go. This audio journal club is intended for educational use only and does not constitute formal medical advice.
Always follow your institution's protocols.
Also, this deep dive utilizes AI-generated voices, so you may occasionally hear slight mispronunciations of complex medical terms, drug names, or author names. We appreciate your patience with that.
Thank you for joining us on this deep dive into the R2D2 ICU trial.
Stay curious, protect your patient's dignity, and we will see you next time.